Hello, this is John Kanelopoulos from our center in Athens, Greece, the LaserVision Ambulatory Surgery Center, Clinical Professor of Ophthalmology at NYU Medical School, New York City, New York. Very excited to share with you some of the latest technique that we introduced this last year, 2020 and 2021. We're seeing here, besides beautiful eyes and color, great fundus, a young lady that has thin, relatively corneas. We'll see this in the anterior segment OCT. Here, 507 microns thinnest on the OptiView Avanti. A little bit funny looking central epithelium. Also, the left eye is at 508. Due to some dry eye symptoms that she had, we opted to go with PRK instead of LASIK. We also see in the pentacams here the thickness maps. In my opinion, they're ovoid, the thickness patterns, and skewed temporally. So these for us do raise suspicion for a very slight tendency for keratoconus. We can also see the truncation of the astigmatism here on the placido images of the right eye. We'll see placido disc images of the left eye. Although we cannot call this keratoconus, the above really constitute the indication for us to perform PRK. We have the pleasure of using the Innovize artificial intelligence software by Alcon Wavelight, and we see here the measurements from both eyes of this young lady, which combines action length measurements, wavefront, and sine fluke tomography. We always back up anterior segment measurements and action length measurements, pupillometry, and we'll see that our clinical refraction will come up in our infamous, by now whoever has followed our courses, pink sheet. We also have the sitemap, the Innovize refraction in the bottom. We're collecting data from all the different measurements, and Innovize uses artificial intelligence that really ray traces 2000 rays towards the lens of the eye and using the wavefront measurements from the retina to the anterior lens of the eye. We're seeing here the Innovize determined measurements. See how the accuracy gives it -213, 0.26 of cylinder. And we're going to use the numbers suggested from the Innovize software. Per se, no surgeon alteration or modification or nomogram. Our classic draping of the upper lashes will do the same thing with the lower lashes. And I like to always spend a little time and describe this to beginning surgeons as sterility of the laser vision correction procedure, whether this is PRK, LASIK, or SMILE, is key. We use an aspirating speculum here, and this is probably the toughest part of the procedure for a PRK patient. And we will, of course, this is done under topical anesthesia. Alkane we use in Europe, PRK in the US. And we're going to focus. We've used several drops before to loosen a little bit the epithelium. I'm going to dab the surface with a dry Wexel sponge and then use the EBK device by Orca to perform a very controlled and small in diameter, as you can see here, de-epithelialization. This is a blunt plastic device. We've reported on this and it's great efficacy, but the novelty of the case that I'm showing you here is that we're only going to remove the epithelium enough to fit the ablation that we saw before in the treatment plan that has a total diameter of about 7 millimeters in the horizontal axis and 6.5 millimeters on the vertical axis. Thus, I'm attempting here to create an ovoid epithelial defect just big enough to fit the ablation and wiping out. Very important with EBK to make sure that Bowman's is exposed throughout. You don't want to leave an island of epithelium because that's going to create an island of untreated cornea. We see the nice shininess of Bowman's membrane, and we're focusing the laser. Laser reads the RS anatomical landmarks captured by the sitemap device and limbal vessels in order to correct for cyclorotation and deliver within seconds. And we see the EX500 excimer laser here doing its magic and performing the ablation. We see how nicely our ablation fits within the epithelial defect created. Of course, for the beginning surgeon, you may opt to perform an epithelial defect a little bit larger than what the ablation will be, but experience teaches that we're exactly where we should be. Mitomycin 0.02 and we're soaking for a total of about 15 to 20 seconds in order to reduce the potential for scarring. We will rinse with chilled BSS following the mitomycin application. This is always an unpleasant surprise. You can see the patient doesn't really like this, but we're encouraging compliance here. I'm in direct communication with the patient. Very important to have all the measurements, all the data done before. We're starting with Bromfenac drops per lens in the US, Yelox in Europe, moxifloxacin drops, and dexamethasone in Europe as a topical steroid, Predforte in the US, and a bandage contact lens that's soaked in Bromfenac solution. We have found this a miracle as far as almost eradicating first night postoperative pain in PRK cases, plus the smaller epithelial defect and the fact we did not use diluted alcohol. I'm not a big fan of transepithelial epithelial removal, as any irregularity of the epithelium will be moved into the stroma. We're finished. We're removing carefully the speculum and the tegaderm drapes. The beauty with this procedure is that the patient will sit up from the bed once the other eye is treated, and will invariably have 20/20 vision right after the procedure, really changing the paradigm for PRK, which usually had a week of blurry vision and thus in very significant pain the first night, thus making it a very poor second option to LASIK. Here again, we're going to go back to the same routine, and I know this may look boring for experienced surgeons, but it's very important for each individual patient, all these steps to be taken into account. The room has to be focused on the patient, no discussion in the laser room on any other subject rather than everybody addressing the patient. The numbers all have been checked before we have gone into the room. We've taken the time out to make sure that the patient's identification matches the numbers on both our laser device, the X500 excimer laser, or Femtov, who were performing LASIK. Here again with the Orga EBK device. This is designed to do a complete deepithelialization of the cornea. I'm using it in different orientations, as you can see here, and I'll probably do a better job in this left eye, as you saw that I went a little bit over in the superior cornea in the right eye. The advantage of the miniPRK, and we presented this in the major ophthalmic meetings, ESCRS, ACRS, and the Academy of the last year, despite the coronavirus problem in spreading ophthalmic knowledge, is that besides the fact that the pain is minimized by the smaller epithelial defect and the Bromfenac drops, we essentially achieve complete reepithelialization in 85% of the patients by day 3. And this is phenomenal in our PRK experience. I personally became certified in PRK in Boston. I can never forget this, in 1996. I had done procedures internationally since 1994. LASIK procedures, and here we're focusing the X500 excimer laser. So I was talking that we get complete revitalization in the majority of patients by day 3, if not day 4 is the last day of the bandaged lens and return to normality. We're seeing here again that the total of the ablation fits within the much smaller epithelial defect. Remember, the cornea has diameter of about 12 millimeters. We're looking at the horizontal defect of about 7, maybe 7.5, and vertical about 6.5. Again, our mitomycin 0.02 milligram per ml for depending on the amount of myopia. We saw in the preoperative measurements this eye has only 2+ diopters of myopia and a little bit of astigmatism. The other eye was at 4+, and cold chilled BSS afterwards to rinse the residual mitomycin C, and start with the Bromfenac drops, the moxifloxacin, and the dexamethasone. This procedure was performed in Europe. We had the pleasure of using the Innovize software since its release by CE Mark, the equivalent of the FDA approval for Europe in fall of 2019. We're the first team to publish results with this amazing technology in LASIK in 2021, and in using it as a customized normalization in the Athens protocol for keratoconus in press for the Journal of Cornea in 2021. Our bandaged contact lens soaked in bromfenac onto the surface. We've completed the procedure. Patient will, as I mentioned, sit up. They'll be invariably at 20/20, 20/25. Of course, the vision will blur a little bit between day 1 and 2 when the reepithelialization will reach the pupillary aperture, and we, of course, explain that to patients to reduce any anxiety produced by that. But it usually remains in the 20/40, 20/50 level on that day 2, and finally reepithelialize between day 3 for the majority, the latest day 4, and back in normality in less than a week. We're seeing here the eyes just a week later, pristine, and possible to tell that the patient had laser vision correction. Patient ended up with the end of eye saw for a 2010. We see here the early epithelialization and the remodeling of this PRK procedure and how well the center has epithelialized. This is day 4 after procedure, and how nicely we can see the broad optical zone achieved on the sine fluke tomography images for the right and left eye now, how well centered the ablation is. A very helpful procedure in our armamentarium, really making it here our proof of concept, our sight map measurements post-operatively, verifying that the residual refractive error is essentially plano. We're slightly hyperopic the first few weeks due to the epithelial remodeling, and we reach the plano level at 1 month. This is John Canelopoulos. Hope you found this interesting, and thank you so much for your attention.